Good afternoon, everybody. I'm Lisa Stone with Parenting Aces, and I am joined today by Kayla Fujimoto Epperson, who is a physical therapist, but more importantly, a former collegiate tennis player. Kayla, welcome. You and I did a podcast a few months ago, right, I guess, at the beginning of the pandemic or right before the pandemic hit, and man, a lot's happened since March.
Yeah, thank you so much for having me. I'm really excited to be here.
Well, we're glad to have you. I'm going to just flash your website and the link for your website up on the screen right now. The Athlete Connection is your physical therapy practice, and this is the web link for anybody wanting to take a look. So why don't you share briefly with our audience a new study that you have just published and the reason that you decided to pursue this line of research?
Yeah, definitely. So I'm really honored to have just published this article. It's called Backhand Wrist. It's a new tennis-specific diagnosis for elite level junior tennis players. I worked on this with Dr. Miyu Jayanthi from Emory University, as well as Dr. Michael Goschak, who's at Emory, and then Dr. Gary Lurie, who works with the Atlanta Braves as their hand and wrist surgeon. So kind of the start of this this publication for us, or this clinical commentary that we published, was because I suffered from this injury as a college tennis player, and Dr. Jayanthi during at his tennis medicine program at Emory was starting to see more and more junior players presenting to his clinic with similar complaints of this wrist pain on the non-dominant wrist during a two-handed backhand. And so what we really wanted to do was kind of better define this injury type specifically for tennis players, and then talk about the really sport-specific management of it and conservative management so that players can avoid surgery and hopefully get back on the court sooner rather than later. So in college, I started having this type of wrist pain. I would say it was my sophomore year. I did change my stroke mechanics my freshman year, and that may or may not have played a role in it. But we're finding, based on expert opinion and then just on players that we've seen in clinic, that this likely does play a role in having this injury. I played through it my entire sophomore season with wearing a brace and just kind of playing through the pain. And then it got to the point my junior year that it was really too painful for me to play through it, and I ended up having surgery. And then through my clinical career as a physical therapist, I was still having pain, and it didn't quite feel right ever since I had that surgery. And, using my hands all day long, it was really starting to bother me. I actually filmed some videos with Mark Kovacs. This was last summer, and I was hitting, and it was just the pain was so unbearable that I actually had to have all the hardware that I had put in removed last year. And that was when I was really, we got to do something about this and, try and help players avoid having a surgery, avoid having complications down the line. And so that's kind of where it took me to getting this publication into works with my colleagues. And it was recently published in the Journal of Tennis Medicine and Science in July this year.
Wow. I mean, playing through pain is a common thing that junior players do. They either don't want to admit that they've hurt something, they're scared to go to the doctor and find out that they might need surgery like you found out you did. They don't want to take time away. They're afraid of falling behind their peers in their rankings, and especially older juniors who may have started the recruiting process and, they're scared they're going to miss major tournaments. And so they just continue playing through it. But with this backhand wrist, can you explain exactly what the symptoms are so that somebody knows that, hey, if I'm feeling this, I do need to get it checked out, but these are the things I need to describe very clearly to my doctor or my physical therapist?
Yeah, definitely. So for backhand wrist, it's ulnar wrist pain. So the ulna is this long bone on the outside of your wrist, on the pinky side of the wrist. And tennis players will complain of pain kind of right in this kind of spot, right where the end of that long bone in the forearm, just before the hand area, you can feel like a divot in that space.
I'm just feeling it on myself right now.
Yeah.
Okay.
So some players might have pain there or right on top of that bony part on top of the forearm and the pinky side of the wrist. And usually they'll complain of pain hitting two-handed backhands at ball impact. Pain that worsens maybe throughout practice or throughout a match, so over time, or pain that kind of came on suddenly without a really true injury incident like a fall or anything like that. Well, that might exacerbate some of the symptoms, but it's really kind of pain that comes on out of nowhere, maybe from overuse, and it's on that two-handed backhand, or on a shot where you're hitting really heavy topspin, they might start feeling it.
So it's on the non-dominant hand on the backhand side, but it could happen, you're saying, on the dominant side on a forehand if you're hitting a lot of topspin because of the pronation, or?
Yeah, so for the purpose of our commentary, we really focus on non-dominant wrist pain, so during a two-handed backhand, but some of the mechanics and some of the injury risk patterns are prevalent on the forehand side as well.
Okay. And so it's that pain on the pinky side, it's specific to that side. And it's much like we talk about tennis elbow, which is a diagnosis that's been around forever and doesn't necessarily limit itself to tennis players. That tends to be more tendon driven though, right? What is this? Is it a tendon? Is it bone? Is it muscle?
Yeah, so when we get into kind of the anatomy, it can be a number of different things, which is why we really wanted to define it. It's difficult to define this type of wrist pain because there are so many different structures in the wrist in this area. And so you really have to have a keen eye during the clinical exam to kind of differentiate what structures are actually involved. And in this particular injury, it can be a combination of things. So the first thing that is commonly involved is a muscle tendon, the extensor carpi ulnaris tendon, which runs from your elbow all the way to the wrist and hand. And its job is to help stabilize the wrist during motion. So as the forearm is moving from, a supinated position into pronation, or that kind of creating that top spin type movement, its job is to help stabilize the outside of the wrist, while also helping to kind of extend, but then also drop I'm looking at camera weird, drop the racket head below the ball.
Okay. Oh, you froze there for a second.
That tendon can be involved whether it's developing tendonitis. Oh, sorry.
No, you're back. Go ahead.
Am I back now?
Yeah.
Okay. So that muscle tendon can be involved whether it's developing tendonitis in that area or having instability in that tendon as it kind of rolls over the bone on the outside of the wrist.
Okay.
Another structure that is commonly involved is called your Tfcc. It's your triangular fibrocartilage complex. And what that is it's a cartilage structure that runs from this bone to this bone and inserts into the hand and wrist. And its primary role is to help stabilize the wrist and hand at ball impact, or facilitate load transmission across the wrist and forearm with any sort of impact activity. So that's another structure that can be involved in that area too. And then we're also just generally talking about the space between your ulna, this long bone in your forearm, and your wrist and hand in this area. And there are some anatomical variations that can happen where this space can be maybe smaller in certain people or larger in certain people, and that can sometimes play a role.
Okay. So when you talk about having pain in this area, what type of pain? Is it a shooting pain? Is it a stabbing pain? Is it just a constant ache? How does it manifest, or is it different in everybody?
So I'd say more commonly, it's going to be kind of diffuse pain that's just kind of in and around this area of the wrist. Some players will have like a sharp pain at ball impact as soon as the racket hits the ball and you're sustaining more force through that area. And then they'll probably have, after playing tennis, have just kind of a lot of like deep achiness and soreness that doesn't really go away for a period of time after playing. If it's pain that's shooting to the pinky or shooting all the way up to the elbow, it could be a little bit different and there might be more nerve structures involved. But I would say more commonly it'd be the most pain right at ball impact, and then more just kind of diffuse nagging pain and soreness during the match or after the match.
Okay. I want to just throw out to our viewers, if you have questions, you can type them in the comments and we can see those, and I will offer them up to Kayla for her expertise. So please type those in if you'd like. And so Kayla, I wanted to ask you, you said you had surgery as a result of having this type of pain during your college tennis years. And one of the things that kind of was the impetus behind you becoming a physical therapist was this whole notion of, you know, I wish I hadn't had surgery. I wound up having to undo what the surgeon did, and that was another surgery and meant more time away from the courts. What would be a proper treatment for this type of injury if it doesn't involve a surgical fix?
So I would say the hallmark treatment for this type of injury would definitely be more conservative management. And the first thing that we would probably look at are specific stroke modifications a player can make. And this can be, changing your grip type, changing your ball contact, like your strike zone area, and then also changing some of your mechanics during the preparation phase of that two-handed backhand or during your take back. So number one would be looking at grip type. Western and semi-Western grip types are most often associated with pain on the pinky side of the wrist. And when players have that extreme Western grip, or they're really kind of supinated underneath the racket head on their non-dominant wrist, this can create more stress throughout that muscle tendon I talked about at the beginning, and then also just that space in between the end of your ulnar, that long bone, and your wrist and hand. So that sort of technique can be involved, an extreme Western grip. Same with on the forehand side, an extreme Western grip on the forehand side can lead to involvement of this type of ulnar wrist pain. And this is something that Cici Bellis had surgery on, and I know I'm okay sharing that because she's been very open with her injury and recovery. And she's got a really extreme Western grip, and kind of over time that can lead to some degenerative changes within that area. Another thing to look at are during the preparation phase, or that take back with the two-handed backhand, is the player excessively dropping their non-dominant wrist below the ball to create heavy topspin. And so this motion is called ulnar deviation, or trying to deviate the wrist towards that ulnar side. And again, that's just, decreasing space through that end of the wrist and hand, and maybe creating more force through the structures that help with shock absorption, but also stability in that area. So players that are excessively dropping their racket head and take back, or maybe not using enough of their lower body to get to a good ball contact position. They're catching it a little bit too low instead of up in a more neutral position at waist height. And then over time, just kind of dropping that racket head over and over. We're just impinging on the structure. And that's kind of what I had going on and with my injury. And something that I wish I might have looked at prior to having surgery is trying to look at my take back and changing some of my stroke mechanics there, maybe even my grip type, and switching to more of like an Eastern forehand grip with the non-dominant wrist, and kind of see how that helped. In acute cases, bracing or taping can be used to just try to stabilize across the wrist. So in my whole sophomore year, I played in a tiger paw brace. And that's something that I recommend to players who are in season and maybe can't make some of those mechanical changes right away, or if they, really can't take any rest time. It's a gymnastics brace, but it really helped me with just creating stability, and it was comfortable enough for me to play with it and still hit my two-handed backhand. And then another part of the treatment process would be strengthening. So forearm grip strength, working on your rotator cuff and scapular control, everything kind of up the kinetic chain to just improve stability and force transmission as you're hitting your two-handed backhand.
So you mentioned grip, and I want to kind of delve into that a little bit, because grip impacts everything with a tennis player, right? The way you hold the racket affects everything else in the body, the way you move to the ball, how low you have to bend to get underneath the ball, all kinds of stuff. And grip is often something that isn't really addressed in a proper manner in a developing player. It's very difficult to switch your grip as you get further down the line in your development. I've had coaches try and change my grip now as a 57-year-old woman who's been playing her whole life, and I can tell you it's awful. I feel like a total, I don't know. I mean, I have no space-time control of anything. So fixing the grip from the get-go, making sure that a player has a proper grip for all of their strokes from the beginning so that they can develop that over time and then develop the appropriate strength around that grip is key. And it's a piece of the process that's often overlooked. A lot of junior coaches may just not have the education around grips. They know how to identify them, but they don't understand why certain grips should be used or shouldn't be used at certain times. So as parents, what can we do to make sure that our kids are being taught proper grips? What are some of the things we should be looking out for to ensure that our players are using the proper grips and then, hopefully avoiding these types of injuries? And for some reason, you just muted, Kayla. So just letting you know. There you go.
Yeah, so I think, I'm not a tennis coach, and I don't want to overstep my bounds in that sense, but when a player does start presenting with wrist pain, it is really important to take a look at what specific grip they're using and if they have good form. And then from a rehab side too, as a physical therapist, I think it's hard when you bring your kid into a doctor or to a physical therapist who maybe doesn't understand tennis or tennis grip types. That can also be problematic because they may start rehabbing, just the symptoms and
Right.
the general strengthening, then not making that modification on the court. So then this player, while they're developing strength, they might go back and still be using maybe poor mechanics or mechanics that are exacerbating their injury. And so you're kind of spinning the wheel in that sense too. So as a parent, I think if your child is starting to have wrist pain, consider, grip type and stroke mechanics, and maybe that's something is mentioned to the coaches. Do you think, are there any mechanics that could be involved in, some of this pain? And looking at, are they striking the ball in a more neutral wrist position? Are they really, overly, flicking the wrist to get more topspin, or can they be using more of their lower body to create that spin? Can they try to not be as extreme Western grip with that non-dominant wrist and come more to an Eastern forehand grip? The same thing goes if your player does have to go to rehab. Maybe encourage them to bring your racket with them and show the therapist, this is how I hit my backhand and this is when it hurts, because then the therapist can get a better idea. Okay, well, maybe we need to modify how you're taking back the racket too. And some therapists, if they're not familiar with tennis, they may not make that association right away unless a parent or player brings it to their attention.
Right. And, you are a tennis-specific physical therapist. I suspect there aren't a lot of people out there like you who specialize in tennis physical therapy. So what do you do if you're a player or the parent of a player who is presenting with this type of pain or injury?
So I would just know what are the injury risk patterns associated with backhand wrist. And so this was done by Dr. Jayanthi and his colleagues at the Emory Tennis Medicine Program. They came up with injury risk associations when you do a stroke analysis by video or just watching your player, and they found that the increased incidence or increased risk of developing backhand wrist in a player that is excessively dropping the wrist, and they say more than 30 degrees, so you can kind of visualize here, if they're excessively dropping that wrist toward the pinky side, and then if they're also catching the ball in the contact position below waist height. So those are two things to really look for in your tennis player. And if they are doing that with a more, semi-Western to Western grip on that non-dominant wrist. So I'd say those 3 areas: excessive dropping the wrist below racket height at ball contact, having an extreme, Western grip where maybe they could be a little bit more Eastern, and then getting a ball contact position that is a little bit too low out of their strike zone where they, might have to drop their wrist in order to make good contact and create a lot of spin in that area.
Got it. You mentioned that when you developed this injury, you were in the middle of season, and so you had to figure out a way just to get through the season. This is a common, I don't want to say problem, a common occurrence in junior tennis where maybe not right this minute, but typically there are 3 weekends out of the month or 2 weekends out of the month where the junior is actually competing. And so having the time to rest an injury and make the necessary adjustments to avoid the injury are really challenging. What recommendations do you have around those kinds of situations?
Yeah, so that's always a challenging discussion. It's when a player is injured, is this a playable injury, or is this something that I need to stop, shut down, and take a break? Is it something I'm going to make worse if I keep playing?
Right.
And so, I think it's really player dependent and also dependent on how severe their symptoms are. Like, I wouldn't force a kid to play through a lot of pain. I was in college and at that point, was like, I'm just going to do it. Like, I'm in the middle of my conference season, and to me that made more sense. And if I could wear a brace and, I didn't have any pain with the brace on, then I thought, that's okay for me to do just to make it through those last couple months of season. In a junior player that's maybe developing or in that prepubertal stage, I would be more cautious about playing through pain because they have open growth plates. Maybe they're not as muscularly mature. And that's where we don't really want to push through a lot of pain in that age group. And that might be a period of time where it's like, okay, we need to shut down, maybe work on the stroke mechanic and, try to make a change now when you're younger, as opposed to waiting until, you get a little bit older and this is a much bigger problem down the road. So I think those are things to consider. I'm much more conservative with the athletes that's, under 16 years old and still growing, developing, not really pushing and playing through pain. The college athlete's a little bit different and also depending on where you are in your season. So I don't know if that answered your question as clearly, but it is pretty player dependent.
Right. Well, and I think one thing to consider is, if you are going to play through this pain, are you causing further damage to the wrist? And is that going to follow you the rest of your life? Because one thing we don't want to have happen is for a player to develop an injury like this, and even once they're done with their competitive years, and I'm not saying competitive like I compete, in women's league tennis, but rather in, college or junior competition or whatever, we don't want that injury lingering and causing them problems the rest of their lives.
Exactly. So I would say in most cases that Tfcc structure is involved, and that's the primary stabilizer of the wrist or shock absorber. And that structure, it doesn't have very good blood supply, so it's not really going to heal on its own. And so if you keep playing and you do have some sort of involvement with that structure, and you just create more and more degenerative changes, you could develop a worse injury in the long term going through that than you would if you would maybe address the mechanics or the root cause of why this pain is occurring, so that you're maybe not stressing that side of the wrist as much. I will say that this injury does have one kind of intrinsic risk factor, or a factor that you maybe don't have as much control over, and that can be some people are born with a longer ulna than their radius. So like these two bones, the ulna could extend a little bit longer than your radius, which is on the thumb side of the forearm, and that can often lead to some of that decreased space here in that ulnar side or pinky side of the wrist. And so In my case, when we talk about ulnar variance, so it's how far this bone extends past the radius, and they should be relatively equal. Mine was 1 millimeter longer than my radius, so maybe that did predispose me to having more of this ulnar wrist pain. I think in Cici's case, she had, up to 4 millimeters or more.
Wow.
And so Dr. Lurie, another reason why we did this clinical commentary was because right now there really aren't any clear clinical standards for when to do surgery versus not. And so according to Dr. Lurie, his expert opinion is anything less than 2 millimeters difference in that length of the ulna versus the radius on the outside of the thumb side should be managed conservatively, and really trying to work on strengthening, stroke modification, grip strength, more control through the shoulder, and stroke mechanics. And anything from 2 to 4 millimeters, he recommends a less invasive procedure where they just kind of go in and shave down a little portion of the ulna and create a little bit more space in that area. And then anything beyond 4 millimeters, he recommends having where they go in, they take a little piece out of your ulna, they shorten it, put a plate and screws in, and then call it a day. And that's what I had. And so when
For 1 millimeter, you had that?
Yeah. So when I found that out from him, thinking back, I was like, wow, I really wish I might have spent more time on the conservative management or just trying to understand this injury a little bit more, because I ended up having those complications down the road where my hardware really started to bother me. I had a longer recovery because it was a more invasive procedure. And when I looked into the research, there really aren't clinical standards for this. So that's why another big reason why we wanted to get this information out there is because even if you do have that anatomical variant, there are varying degrees of it that would warrant better outcomes with surgery versus not having surgery.
So just so I'm understanding this clearly, the first step in the process, if somebody presents with backhand wrist, is to look at stroke mechanics and make adjustments if that's warranted. Assuming stroke mechanics are fine, then the next step is working on grip strength, forearm strength, stability through the rotator cuff, the shoulder, and making sure that all of, up the chain from the wrist is strong and stable and able to sustain the repetitive motion of hitting backhands, which are a necessary part of tennis for most of us. And then after that, if that doesn't work, then the next step, the most radical step, would be the surgical procedure, depending on the differential in the length between the radius and the ulna, either shaving off a little bit of the radius or going in and actually cutting off a portion mid forearm and inserting a plate. Did I say that right?
Yeah. So yes. And I think one other step in the conservative piece would be playing with a brace or taking a period of time off as well. Yes. And then an older, athlete, maybe a college athlete, they can, if they're in season, some sort of a cortisone injection that might just help with some pain management and managing some inflammation in that area, which I had while I was in season, and it did help a lot with just masking some of that pain while I was in season.
What about using things like Advil or, some other sort of anti-inflammatory that's less invasive than getting a cortisone injection?
Yeah, I'm really not a huge proponent of using pain medications, just because, especially in the younger athletes, we want to really know why this is causing pain. We don't want to just mask it. And so personally, I don't like recommending that.
Okay.
And I would recommend more of the, stroke mechanics, rest, modifying your training or activity before doing that.
Is this injury something that heat or ice can help with?
So that can help kind of manage symptoms, like after a match or after playing or in between matches, if it's something where you're playing through it. But again, I think you have to think kind of global, big picture. Why is this happening? And that's where some of the changes, like doing a strengthening program or a rehab program, in addition to making those stroke modifications, is probably your best bet for the best outcome over time.
If somebody is, let's say they've been diagnosed with backhand wrist, they're going to physical therapy, they've been released to go back to training or competition, what are some of the maybe warm-up exercises they can do to get the wrist ready to play? What are some of the recovery exercises they can do to manage as they're going through the recovery process?
Yeah, so I think the number one thing, and I would say, is working on a lot of your rotator cuff strength and scapular strength. I think a lot of people, when they think about an injury, they tend to look at just that part of where the actual injury is occurring. But it's really important as a tennis player to think about, am I really using my lower body, my core, my shoulder, and all my stabilizing, my trunk muscles? Am I warming those up properly before a match and really activating and using those? Or am I just using a lot of, wrist and forearm and maybe creating more stress to that area? But in addition to doing, the trunk and core stability and rotator cuff warm up, I would say working on anything with your grip strength, whether that's doing wrist flexion exercises, wrist extension with either, a band or with light dumbbells, doing controlled deviation side to side. So from thumb side to pinky side, that can help to establish better stability across the wrist and forearm. And then also doing, so I like using that, I'm sorry, I don't have any props with me, but using a hammer and doing controlled pronation and supination, and just trying to work on, again, stability and controlled motion with that hammer. It's usually top heavy. And then it really forces the wrist to try and stabilize that extra weight as you rotate side to side. So those would be more kind of strengthening or warm-up exercises prior to tennis activity.
And then what about after practice or after a match?
So afterwards, this type of injury where it's located, it's really not associated with like a loss of motion or anything. Most cases, it's happening because players have too much mobility or maybe some instability in the area. So it's not like anything afterwards where you would need to be doing stretching or something like that, but maybe continuing to do more stability exercises after a match so that you're, again, just reinforcing better stability across wrist and forearm, and that probably make it feel better than if you tend to just overuse, and then afterward it's just kind of sore and tired, and you can do those activation exercises to actually make it feel better.
Okay. I mean, what's so interesting to me about this injury is it's easily diagnosed, it sounds like, if you know what you're looking for. If you understand where the pain is and what your grips are and how you're making contact with the ball. For somebody that understands all of that, you say, oh, yeah, you've got backhand wrist, and here's what we do about it. And changing the grip is, again, it's a simple thing to do. It's not easy for the player, but it's something that can be done. And typically, it takes anywhere from 2 to 4 weeks to kind of groove that grip change so that it becomes comfortable. Is that a fair timeline?
Yeah, I mean, I think, again, it depends the level of the player too, and how much body awareness they have, how comfortable they are with the changes. And
yeah,
but I think that that sounds like a reasonable time to me.
Okay. So we've got a question. What's your therapy degree?
I have my doctor of physical therapy.
Okay. Because it's a mom is saying that doctors don't typically recommend cortisone for professional athletes. What do you know about that?
Yeah, so actually I am not recommending cortisone injections. I'm just explaining what my personal experience was. I was given a cortisone injection when I was in college going through this injury, and I think there's a good debate out there on usefulness or not, and whether they're recommended or not. And I'm not going to open that can of worms because that's not I'm not a medical doctor to make those decisions. But I'm a huge proponent of more conservative, not masking pain with pain medication or injections. I think at the time, I was in the middle of my conference season, and I was like, what can we do to just mask some of this pain just to get through it and then rehab it after season? So I was kind of in a cleanup job situation, and that's really why I'm doing this work now, is because it's not a fun place to be in, and it's not somewhere that I would want, my athletes that I rehab to be in those situations.
Right. And so I think, just to clarify, Kayla was describing her experience, not what she would necessarily recommend for anybody else. So physical therapy, grip change, rest, all of these things are definitely more favorable options and more desired options for an athlete suffering from backhand wrist. But to me, what's so interesting about this is that this is kind of a new diagnosis.
Yeah, so that was, one of our main goals was, just like we have a diagnosis for tennis elbow, like we wanted to come up with this new tennis specific diagnosis, because ulnar wrist pain, or pain on the pinky side of the wrist, is really common in athletics and, golfers, and anything where you have to grip an implement, hockey, lacrosse, baseball. I've worked with a softball player that has had symptoms of this too, and similar principles apply as far as the treatment goes. Is it something mechanics related? Is it related to an actual strength or stability issue? But I think our primary goal was to define it as backhand wrist, because from the medical side, there isn't as much of a tennis knowledge. And so from your perspective, when we talk about stroke modifications, like, oh, that makes complete sense. I could see why that would help this area. But from the rehab side, in my experience, you don't run into a lot of therapists that, know a lot about tennis and tennis specific, strokes or grip types. I mean, some players don't even know grip types when you ask them what grip they use, and they'll come in and you're like, well, what's your grip? And then they're like, well, I don't know. And you hand them a racket and they're like, oh, okay, now that's your grip. So yeah. I think that was our goal, was to just increase the awareness around it, and so that it can be better recognized, and knowing exactly what structures are involved, and then implementing those specific stroke modifications from a rehab standpoint. Because like I said, a player can come in with wrist pain on their pinky side of their wrist, and we could rehab it all day and do strength training. But then if they're going back on the court and maybe using some of these stroke mechanics that are putting more stress on the wrist, then the injury may or may not change from that point going forward.
Yeah. So, I mean, making those grip changes, making those stroke changes are an integral part of fixing this issue, recovering from it, and making sure that it's not a long-term problem for the player. What's happening with Cici Bellis in that regard? Do you know? So she's back out playing. She looked good last week.
She's back out playing. I know she's had multiple surgeries in that area. She also had the hardware removal like I did, and I know she's talked openly about it. I don't know if she's actually made a grip change or a stroke mechanics change. That was something she mentioned that they thought about doing, but I think that now that she's had surgery, I think they're just continuing on with the hopes that, maybe now that the anatomical change has been made, that she won't run into as many issues. And that's something else you have to think about too. I think, what's the level of the player, and then is the stroke like one of their very best strokes, and how much do we want to change it? And so I'd say that's a game time decision from the coach and the player. But in our youth athletes, or more of our junior tennis players, and maybe people that aren't at that pro level yet, if they can choose to make that decision at that time. But in the developing players, it would definitely be a stronger consideration.
Sure. What else do you want us to know about backhand wrist, and how we can identify it, prevent it, treat it, make sure it doesn't have long-term effects, negative effects on our kids?
Yeah, I think just starting to use the diagnosis, so that it just becomes more recognizable. So ulnar wrist pain in the non-dominant wrist, or pinky-sided wrist pain in the non-dominant wrist on a two-handed backhand, it's backhand wrist. And then the more we can start using this diagnosis, the more coaches can recognize it, players can start to recognize it. And then, on my end, hopefully healthcare professionals can start to recognize it and know the specific steps as they relate to tennis to treat it. Just like I said, just like we have tennis elbow, and everyone's pretty easily able to identify that now and know exactly what's going on, and maybe some of the initial treatment on their own before they seek medical care. That is our hope with backhand wrist, is trying to maybe prevent this injury on the front end more, or manage it better on the front end from the coach's standpoint or the player's standpoint, and making those tennis changes before having to get into the medical system and maybe be overdiagnosed or over-medicalized and having unnecessary procedures.
Got it. So once again, if people want to reach you, they can reach you on your website, The Athlete Connection. Are you available for video consultations, phone consultations, especially now during COVID? How's that work?
Yeah, so I'm happy to be a resource in any way that I can for parents who want to reach out and have questions. As far as treatment goes, I'm limited to the state of Illinois. I can do telehealth or in person here. We're kind of limited with COVID in that sense, but as far as like actual treatment goes, I can treat you if you're in Illinois, but otherwise I can be a general resource and provide education or advice, recommendations along the way as needed. But I am also free to do, or virtual wellness visits, and if that's more of an injury prevention or sports wellness service, I can provide that to really anyone.
And how does somebody reach you for something like that?
Yeah, so they can email me. I'm at Kayla at theathleteconnectionpt.com. You can visit my website. My phone number is on there too. And I'm also on social media at The Athlete Connection.
Okay, I'm just gonna put this up. So there is Kayla's email address if people have questions, and they can shoot you an email, and you'll respond. And I will vouch for her. She is very quick to get back when you email her. So thank you for that. It's nice to know that we can get a hold of you easily if we need that. Kayla, I think this is really cool. I mean, like I said, I grew up, of course, knowing what tennis elbow was. Everybody knows now what tennis elbow is, even people that don't play tennis. But having a new diagnosis such as backhand wrist, I think the more specific diagnoses and nomenclature we can have for injuries and conditions in tennis players, the more likely they are to get effective treatment to either help prevent the injury or help them fully recover so they don't have long-term effects from that. And I know, that's the work you've been doing. Of course, that's the work Dr. Neeru Jayanthi does as well through Emory Tennis Medicine and through the Society for Tennis Medicine and Science. I said it wrong.
Right. You got it.
Did I get it right? I always get to say the acronym in my head. But are there future studies on the horizon, other injuries y'all are looking at to put a name to?
So right now, I think this is the primary one we're working on, and just trying to get that information out there. When you make publications, the time to actually implement it into actual clinical practice, there's a big gap in how many years it takes. So the more we can spread this message amongst the tennis players and the coaches and parents who are actually going to be closest to this type of injury, the better it is for us to start getting it noticed.
Great. Well, thank you again for coming on and sharing your research, your publication, and your knowledge with the Parenting Aces community. It's always a pleasure to see you and talk to you.
Thank you so much for having me.
Look forward to our next chat. Keep me posted on what's going on in the tennis medicine world. Between you and Dr. J, I feel like we've got it covered here on Parenting Aces.
Sounds great. Thanks, Lisa.
Thank you. And to those of you watching, thanks so much for tuning in, and we'll catch you next time on Parenting Aces.